Good morning, everyone. Shall we start? Is the screen visible? Okay, shall we start? Okay, so today's topic is National Health Mission. Okay, so shall we wait for some time, or how many students are there in 7th sem? Okay, but only 62 are there. So we'll start anyway. So today's topic is National Health Mission. Okay, so can anyone tell what do you mean by National Health Mission? When was it launched? Anything, any information regarding that? Am I audible? Okay, so first we'll start by asking you what are your priorities this week. Can anyone tell in chat box? So just a brief informal discussion. So any of your priorities this week or this month? So we'll wait for other students to join. Meanwhile, you can use your microphone also. Anything related to your studies, related to your life in AIIMS Jodhpur, anything like that. So are you having any end semester exams? This year, are you having any exams? Okay. So usually you don't have exams in 7th semester. Usually, is it like that, or do you have any end semester exams? So till now you don't have. So had there been any exams, then preparing for those exams would have been one of your priorities. Okay. And are the movie theaters open yet in Jodhpur? So as all of us know that it's a Corona time, COVID time. So if those had been open, going there also would have been one of the, if they would have been a nice movie, it would have been one of our priorities. So we have our different priorities in our personal life related to our academic goals, related to our other extracurricular activities. So similarly, we also have priorities for India, to provide healthcare to India, which is now more than 1 billion population. Okay, so we have our priorities. So the main things which go in any resource for in order to provide any service is manpower, money, and materials. So with that, we have to provide healthcare to 1 billion, 1.3 billion population. Okay, so so mainly, so based on that, we have to have some priority conditions where we have to invest money. Okay, so which are our goals? So okay, because resources are not unlimited, so we have to identify what are our goals and targets and how we are going to achieve them. Okay, so basically for any policy, any program on a national level, okay, in order to achieve any objective on a national level, we have a different. First, we have an objective related to any health program. Then we have certain goals, okay, which are specific. Okay, that a certain indicator has to be reached by a particular time. And then we have some prescriptions, some recommendations are there. Okay, so those things are there, and for this National Health Mission also. So as you know that the health services are being provided in the community. We have primary health centers. So those services are being provided there with we have a certain objective in mind, and there are certain goals. Okay. So basically, first we have to know what is the objective. That is, objective is usually it is defined as to achieve acceptable standard of good health among the general population in the country. This is a broad objective of any health program, any of our public health system which we are having. Okay, of which AIIMS Jodhpur also is a part. Okay, so this is our objective, and then we have certain goals. Okay, and specific targets. So we will come when we are discussing about National Health Mission. We'll come across that. So how it was started? How National Health Mission was started? It was launched in 2005, April 2005. Okay, and then subsequently this was as National Rural Health Mission. Okay, so that time you might have been in school. So by that time we had already joined the medical college. We were in third semester. So then the NRHM, that time it was newly launched. So some of the things which it's very commonplace. For example, you would have heard of ASHA. So can anyone tell what is ASHA? What do you mean by ASHA? Now there are around 80 students. So I believe more interaction will be there. Yes, correct. Jagriti has answered. So yes, that's the full form of it. And basically, ASHA is a worker which belongs to the community in the village, and they usually cater to 1,000 population. So this is the concept of it. So they are also selected in accordance with the Panchayati Raj institutions. So usually there is a village level meeting. Okay, and according to that, they are based on in the village level meeting, they are selected in accordance. There is Sarpanch, and so it's a community level activity. So we have to understand all these features which we know now have come from 2005 onwards. So ASHA was not there before 2005. So when we are in first year, there was no concept like ASHA. So now you are totally in this NRHM era, post NRHM era. So whatever we are seeing as related to the health programs, so mostly it is under the umbrella of NRHM. So NRHM, and subsequently it was renamed as National Health Mission. Okay, so it's very broad, that you have to understand. Okay, so just one example of ASHA I have given. So this thing you should keep in mind, that ASHA was started under NRHM. So one key thing I have told. Okay, so although there are many details, we'll just discuss the concepts. Okay, so later National Urban Health Mission was started, you should remember, after 8 years in 2013. And then both these missions were combined. Okay, and then it was renamed as National Health Mission. It is actually the National Rural Health Mission only, but after combining the urban health mission, it is renamed as a national health mission. Okay. So what was the vision? Universal access, okay, to equitable, affordable and quality healthcare services. Okay. So that means people should have access to healthcare services regardless of their ability to pay. So suppose somebody is poor, suppose somebody is belonging to below poverty line. So even they should be able to have access to the health services. So that was the thing. That was the main thing. Okay. What do you mean by equitable? Can anyone tell what do you mean by equity? It's difficult to define. Can anyone give an example? Yes, according to need. Yes, very good, very good. So suppose, for example, there's a tribal area. So tribal area has a more need. So in that tribal area, we can have an Anganwadi center or Asha worker for a much lesser population. We can give more amount of resources as compared to the population. We can have a primary health center. So there is flexibility in a national health mission that suppose in national health mission, we have a population criteria that one PSC should be for this much population. But for example, in northeastern areas, for example, in the tribal areas, okay, and for example, in those states which are performing poorly, so there is also provision for providing more services, provision for providing more staff, okay, or for example, for having a PSC for a smaller population, okay. So that is an example, and yes, you have rightly stated that according to the need, what is the need? According to that need, the service has to be provided, okay. And it is accountable and responsive to people's needs with effective intersectoral convergence. So what do you mean by all this? Intersectoral convergence? Can we give any example? So it is using the services or provisions of different sectors. For example, health sector is, for example, in this COVID-19 outbreak, health sector was coordinating with municipality. For example, if you see that, suppose I'll give an example, so you will understand what is intersectoral, just a recent example. For example, we had facility of home isolation. So some people who are getting affected with COVID-19, they are having home isolation. So what is done? So there is a facility of daily home visits. So one worker from the municipality, from the municipal council, they will come and they will visit the homes. So it is, while testing is in the hands of the health sector, so the home visit part is, if it is being done by the municipal municipal commissioner, so then that's an example of intersectoral coordination, and there are many examples. Okay. So we'll see. So that was the focus, that is trying to converge various sectors to achieve the health, because you know that there are many factors are there which influence health. Okay, it's not only a medical thing. It's not only that you have to remember. Health is not determined. Many times we tell that it's healthcare. So hospital will tell it's healthcare. It's not healthcare. It's basically medical care. So basically, what we do in a hospital is somebody gets sick, we treat. But healthcare is much broader than that. So even prevention comes in healthcare. Okay, and even suppose immunization comes in healthcare. Okay. Even suppose provision of food ration, that also comes in healthcare because it's linked to nutrition. Okay, so that aspect was there as a vision of NRHM and subsequently National Health Mission. So what were the focus areas? So these focus areas already you would have seen in different programs. One is decentralized health planning. Okay, so decentralized health planning means, earlier, what was the concept was the planning used to happen at a central level. So now there is more incentive, there is more provision for planning at a village level, at the primary health center level, and at the district level. Okay, and then second aspect is expanding the outreach services. Okay, so that will mean that strengthening the sub centers. Okay, then for example, any of the ambulance services. Okay, so outreach services, and then your main example you can quote as ASHA. ASHA is the community outreach services, it is there. Okay, So those services are strengthened. Okay, so that is one thing. Then we have community engagement. So engaging the community, as I already stated, Panchayati Raj institution is involved in recruitment of ASHA. Okay, and then there are various committees out there. For example, in PHC, there is something primary health center level. There is something called Rogi Kalyan Samiti. So we have those things. Okay, and then human resource development. The provision for training of manpower, human resource with manpower, staff. We are all human resource. You are human resource. We are taking class, that is part of human resource development. Then public health management. So this is like management, better management of many of the health programs. So there are so many disease-specific health programs also, which are there under NRHM. So they have to be managed properly. That means the data related to those programs have to be reported at the correct intervals and on a timely basis, and monitoring has to be done. Okay, and the another important part is this financial management. So this program management includes this financial management also. Okay, so adequate provision of funds according to need. Okay, so those were the focus areas, and as already you told, focus on equity, prioritizing on health of tribal population, those in urban poor and lower socioeconomic status. So that part already you have told. So those were all the focus areas with which, keeping in mind, they have launched this National Health Mission. So what were the objectives? Mainly we'll touch upon those. So before that, can anyone tell what is the recommendation for a PHC? How much population is there for a primary health center? How much population should it cater to? Yes, 30,000. Yes, very good. And sub-center already we have discussed in last IDSP class also. And sub-center, it is 5,000. Okay. Yes. So that part we have to keep in mind. The structure we have to keep in mind. That structure is same. It will never change. Whether you are studying any other health program. And last class we had already studied IDSP. So integrated disease surveillance. So what is that? That is also included under the umbrella of NHM. So ideally you should have an NHM class first and later other classes, but it's okay. You can later integrate all these things into one. So that's why we will be discussing NHM in a very broad way. Okay. So what were the key objectives? So you will see that most of the health programs objective will be covered in this key objectives. So first is reduction of infant mortality rate and maternal mortality rate. Okay. So we had, I think, your RMNCH plus A class. Reproductive maternal, I think that was for yours or 9th semester. I'm not able to remember. So that aspect is being taken care. Okay, so that is a very, very key important objective, is to reduce infant mortality rate and maternal mortality. So what is IMR? What is the definition of MMR? All those things you should be clear. You should go home and read. And maybe next month I'll ask you. So that is also usually taught as part of your health indicators. Then population stabilization. Okay. So how to achieve population stabilization? By ensuring access to family planning services, contraceptives. Okay. Till the community level. Okay. That is by ensuring access till the ASHA level. Even ASHA is having the contraceptive pills. For example, oral contraceptive pills. Even ASHA can give them. So those things are available with them. Then universal access to public health services, those were the objectives. Then prevention of communicable and non-communicable diseases. Okay, so that is integrated. So the maternal, reproductive and child health part is included in that. Okay, that includes family planning objectives. Okay, and then it is the comprehensive providing primary health care. So universal access and primary health care are almost same, because obviously you have to provide primary health care to cater to the bulk of the population, for example, in rural areas, then only you can provide universal access. So it is actually the same point. Okay. But it has been slightly differentiated. Then local health tradition. That is one thing in Ayush was there, that having Ayush. That what do you mean by Ayush? So before that, it was mainly allopathic based. So with NHM, this concept was introduced to mainstream Ayush, means Ayush practitioners were giving services in private places, and there are some Ayurvedic college, homeopathic college were there. But having an ability to provide those services at the PSC level and at the hospital level. So what do you mean by Ayush? Can anyone tell? Ayush? Yes, Ayush. So all these traditional systems of medicine. Okay. Yes, Jagrati has answered correctly. So that is Ayush. And already you know, it's a very popular term now. Ayurveda, Unani, Siddha, homeopathy, and now we have introduced yoga. Yoga also is that part of it. Okay. So yoga also is included in that. Okay. So this I'll share the slides also. So this we have briefly summarized what are the 5 thematic areas, key things, focus things of NHM. So you can, if you remember these 5 things, you can understand NHM. And just remember one example of each of them, because it's very difficult to just remember some thematic, because as we know, sometimes community medicine can be abstract. It means we need some examples to understand. Even when we study or try to know, we have to remember them. So first is community engagement. Okay. So community engagement, you can remember example of, for example, ASHA and involvement of Panchayati Raj institutions. Then health system strengthening. So health system strengthening is provision of funds to the PHC level, funds for there is some at sub-center level to recruit staff, okay, to build buildings according to guidelines. So that is the health system, the building, the staff, okay, and the management system, that is the health system. And human resource management. So there is more provision of providing contractual manpower at district level and block level. Okay, for example, I'll give you an example. There is something called block account manager. So they will come call us BAM. Okay, so for what they realize is, for management of all these programs and account fundings, we need an account manager at a block level. So a block level, as you know, is around 1 lakh population. So there is a account level post. So all those posts were newly created. For example, okay. So that I'll just give you an example. Then again, there is a block health manager. So health manager post was created because what they saw is doctors are not getting, they are involved in patient care and they don't have the management of the PHC and health system that requires so many things. Okay, for example, whether the person is coming on time or not. Okay, for example, delivery room, proper supply of disinfectant is there or not. Okay, this chart is there or not. So management requires so many things. So yes, they were definitely earlier, those medical officer in charges who were very interested, they were able to manage themselves also. But that additional hand, so health manager is a non-medical person. So they are all supporting. So, so what is the concept is in NHM is that health is not only a medical matter. So that is what also is there, involving people from accounts department, involving people from IT department, involving people with a managerial background. So all these things was recognized. The multi-sectoral nature of health is more recognized in NHM. So all those people, as we had seen in IDSP, there is recruitment of data entry operator and there is building of IT network. So all the knowledge has to converge in a health. So that part was recognized under NHM. Then public health planning and financing. So better financing, more flexible financing. So there is something called untied funds, you should remember. So whenever financing is there, you should keep in mind some concrete examples. Okay, like one thing is untied funds. That, for example, in a PHC, if you want to put some curtains, okay, or if you want to put some partition, okay. So there are many things for which if we do through traditional channels, it will take a lot of time and it happens. So what they realize is that there should be some untied funds. Okay, suppose some tube light is not working. Small things like as sub-center tube light is not working. So what she can do, what ANM can do, she can use the untied funds. Okay, so there are some guidelines regarding that untied funds should not be used for drug purchase, but for those things, okay, and then she can use the untied fund and she can maintain a record, and that is fine. So that thing was given, usually those that to improve the services. Okay, So those aspects were given to improve the services available, okay, at sub-center and PSC level and district hospital. So that part was given. And then monitoring, as already we have told, certain standards are there, and monitoring aspect has been strengthened under the National Health Mission. So community engagement, already we have seen some examples. For example, there are committees at all levels, at PSC level, at the district hospital level, there are committees. Like for what I told is Rogi Kalyan Samiti. So in that, patient representatives and community representatives also will be. Okay. Untied funds I have mentioned, involvement of Panchayati Raj bodies. Okay. And involvement of local community organizations which are involved in health. Okay. And there is something at village level, we have something called Village Health and Sanitation Committee. So that in that the ASHA is there. Okay, ASHA is there, Anganwadi is there. So that, for example, if you know that, if you see that suppose immunization is taking place, so it is usually that Village Health and Sanitation. So we have a day, we have a VHSND. So we call Village Health, Sanitation and Nutrition Day. So that on that particular day, we have the meeting with mothers. For example, mothers come for immunization. So we have a meeting, they have a meeting also. So immunization is not the only aspect in that. There are other things also. Antenatal care. Okay, so at least usually that service is provided at least once in a month. So usually many places it will be fixed on a Wednesday or Friday. So that part of the immunization is also provided. Okay, there will be meeting of mothers, and then takes place at the Anganwadi center. Okay, so the ANM who is there in sub-center, they come there. Okay, ASHA worker is there, she helps to mobilize people there. So that's like that's a system is there, and it is supposed to be visited by medical officer also for monitoring. So those systems are in place. Okay, and they have been built up. So there are some example of community engagement. For example, this is a photo from Sitamarhi district in Bihar, where this filaria survey, you can see this is in school. Okay, in school, children are being educated are being told about filaria. Okay, so this is one example of community engagement which is being done. Okay, so this is one example which is like showing audiovisual, making the people aware in the community. This is another example, making people aware in the community by showing videos related to Kala-Azar. So you can see that. So these are all aspects which is there, which can be done. So which can be done, and the resources which are needed for those health education, they can be obtained, they can be purchased. Okay. So okay. So next aspect we will come to this health system strengthening. Already you are clear. So this was an important thing, and all of you have told very well. Okay, that's I was happy. You told that sub-center is 1 per 5,000 population, and primary health center is 30,000. Community health center is 1 per 1,20,000. That is correct. So same thing for a difficult tribal and hilly area. That's what I was talking about, equity. So for a tribal area, for example, even in 3,000 population, you can put a sub-center, because as you know that, because if the population density is less in a hilly area, if in order to cover 5,000 population, it will be very difficult. Maybe the next place which is there, it's across a ravine, and because if you go in Himalayan areas, those areas, anytime you get a chance for trekking, it is very, very difficult to reach there. There are photographs in which, like in Arunachal, they have ropeways, and for immunization, they have to send the vaccine, and person has to go through the rope. So it is a different reality. So for that, again, we have to have flexibility. Okay. And we should be able to have a primary health center for a lesser population. And suppose it's 20,000, that's the norm. But if it is, we want to set up PSC for 15,000, that also is possible. Just we need a approval at a district level, and we need a proper justification, and it can be done. So that flexibility is provided. Okay. Because suppose something, and it is also applicable in Rajasthan also. Because Rajasthan also is a difficult area. We classify it under a difficult area, desert area, Western Rajasthan. Okay, so in Western Rajasthan, if you see, the PSCs need not be of having a very large population. It's around, you can see that around 30,000, 28,000 population, which is fine. That they can be, if you see in our own PSCs, if you see in we have Dhawa, Dhundara, and all, they don't have a very large population. So because they have been classified under difficulty, the western part of Pakistan, desert areas, population is sparse. So we cannot have, if we have, so that part has to, flexibility is there. Then same thing for CHC, we have a smaller population, you just reduce by 2/3 for a difficult hilly or tribal areas. And staff requirement is also there. So these are the norms which were given. Okay. And then providing 24/7 services at PSC. Prior to that, 24/7 services, 24-hour services were not available at all the PSCs. Okay, so this aspect, initially there were around 50% of the PSCs were made 24/7, but later all the PSCs have been made as 24/7. So that service was provided. So because many of the emergency services, for example, injury, for example, need for delivery, so all these services need 24/7. And then strengthening of ambulance services. Now you see, because that's what I'm telling you, you are all in this NRHM era. So whatever you are seeing, like I'll tell this example of ambulance services. Yes, so this is one is this 102 ambulance and another is 108 ambulance. So just what is the difference? Many times it is asked. So you can see 102 ambulance is actually a rapid emergency response system. Okay. And it is at certain nodal centers. It's located at those centers. It's just almost like you can compare it to like this fire tender. And it is mainly for referral and mainly for pregnant women and for injury. For example, road traffic injuries. So 102 is made as a rapid responder. Whereas 108 ambulance actually is a basic patient transport system. It is situated at the PHC and at the district hospital, at the health center itself. And 108 will have this facility of dropping back also. Usually 102 is not a dropping back facility. 108 can drop you back to your own place. And so pregnant women and neonates can call and then 108 can be utilized. So there is a separate program also. So there is something called JSS scheme, Janani Shishu Suraksha Karyakram. So under that you can use 108 ambulance. Okay. And it is usually positioned at health center. So 108 is having the more serve and then it can drop back also. That is important. And for neonates, priority is given for pregnant women and neonates. And 102 is for rapid response. Okay, so that you should realize, like 102, you can remember is almost like a fire tender. So it has to be fast. For example, in road traffic accident and all that, 102 is important. So then flexible financing, that one of the pillars that we had discussed, the 5 things, 5 key points, flexible financing. So we had already discussed that untied funds. Untied funds, what do you mean? Untied fund is, what is the difference between tied funds and untied? So tied means almost it's tied to some purpose. For example, some fund is given to you for purchase of drugs. So that is a tied fund. Okay, some fund is dedicated for paying the salary of contractual manpower. So that is tied fund. Untied fund is which is not tied to anything. So those funds are there. It's like a miscellaneous fund. Okay, so those are facility as given. NGOs are involved, and more power is given to the district health society. So under this NRHM and NHM system, we have this societies. So a health society is constituted, and more flexibility is given, more flexibility that they can take decisions. If a district health society approves, then those decisions can be taken. Okay. Then there is something called money follows patients. So incentives. So suppose for example delivery is there. So delivery is there. So in poor performing areas we have put 1,400 under JSBY, Janani Suraksha Yojana. Okay, so under that 14,400 is given and to Asha 600 is there. So those things are there. So that thing is there. Suppose number of patients increases, you show more OPD attendance. So in NRHM, what is the thing is, you have to show your OPD attendance also. Because if you attend some of the district level review meetings, for example, Jodhpur or any places, They show in a PowerPoint in a district level review what is the OPD attendance, OPD performance of each of the medical officers. Okay, and in that, if your medical thing is less, then they are questioned. Okay, so because if a primary health center is knowing that there are more number of patients coming there, so then it becomes easy for them to get funds. So that is the flexibility aspect. Incentive based system is there. ASHA worker, you already know. Usually ASHA worker does not have a fixed salary and they get incentives. Okay, so for a particular thing they get incentive. Any of the services, for example, you can remember, for example, if they are in as part of provided for example, a patient of tuberculosis is there. So he or she, if they have to complete the treatment, so if they have completed the treatment and if ASHA has observed the treatment, so then there is a particular amount of money. If ASHA has accompanied for delivery and has helped in antenatal care, then there is a particular amount of money. So incentive-based system is there. Okay, and there is flexibility to recruit contractual manpower. Okay, so NRHM, because it is, again, you will see that it has been renewed many times. It's actually a mission. It has to achieve certain objectives. So again, after 2020, so till now, 2020, again after 2020, again it is being planned for a renewal. So that's why there is this thing in this, that is a contractual manpower will be recruited. Because NRHM, initially it was launched for a period of around 5 years, I think. 2005 or 7 years. So that was it was aligned to the 5-year plan. So that was the objective. So that's why there was this contractual manpower was there. Then human resource management. Okay. Block and district office with management skills. So that means there is recruitment of a block health manager, and at district level also there will be a district health manager. And more recruitment of nurses and staff for health programs, intersectoral involvement in capacity building. So that is there, using other development partners, NGOs, and various organizations had been established, like NHSRC, SHSRC. So what is NHSRC? That is National Health System Resource Center, and same way State Health Systems Resource Center. Okay, and then we have your resource groups, district resource groups, block resource groups. Okay, so all these are. So recently we had a involvement with NHSRC for preparing a consolidated report of their monitoring activity which they had done for NHM. So that part is there. So these are all involved in providing technical support and training, developing modules. Okay. Then there is a district resource group which is involved in performing ASHA training. So we will see, for example, how ASHA training is being conducted. Then focus on multi-skill and periodic retraining. So we know many times, so there are repeatedly funds are coming for training people on an annual basis. So I will see slides, what are there. So for example, this is a training of ASHA workers, which is happening at the district level for Kalazar. So this already supposedly they have been trained earlier. But again, periodic training has to be done. So this is under vector-borne disease control program. They are being trained. So ASHA worker trained in different batches. So that part is very much operationalized. There will be separate funds for that. For them to come to the district headquarters, they will have this thing. Okay. So you are not able to see the uniform here. In this one, you can see the uniform. So this is another training of ASHA. You can see the uniform, this blue border. So that is the ASHA's sari is there. So those training activities, for example, this is a district level. So you can see, so even with the same guidelines, there can be different level of facility. That is based on utilization. Suppose here chairs are there, here chair is not there. So that part is also dependent on, because how the medical officer, how the block person is able to use the guidelines to build up the facility. So what is it? It's actually a management. Suppose there is a training. So if the PSC is able to offer chairs to ASHA workers, and if they have a proper audio visual aid, so wherever the management is better, so that aspect is seen. Okay. So also there is one thing which is not talked usually is corruption. Okay. So that part is usually not talked. You will not see it written in any books, but slowly that is being recognized. So wherever in NRHM what is there, there is this flexible financing is there. Okay. But at the same time, there is this risk of corruption also, because you can just get funds, you can just issue a meeting minutes, you can just use, start a new register, and then, because as in anything, if there is more flexibility, there is chance of misuse also. Okay. So wherever management is better, you will see that funds have been used properly, and that there are, even in Rajasthan, if you see, we have gone to your PSC, if you go to your PSC, some of the PSCs in Dhaba and those areas, you will see this almost, some of the places it will look like a corporate hospital. They are, so how it has happened, under the same guideline, one PSC is looking very good and one PSC is not looking good. That is based on the utilization of fund. Okay, utilization. So that aspect is there. That also you have to see. So there is a critical appraisal of NHM also. You will slowly, if you go to field and you understand, you will get to understand. Flexible financing also comes with a caveat. Okay, so many times, so that aspect of misuse of funds also is there, because they have given a lot of flexible financing that yes, you can justify and you can do. So there are a lot of those things are there. Once you would have heard that time, you would have in school that this NRHM scam was there in UP. So those things are also there. So you have to know, because usually this is not found in any books. People shy away to discuss these things. But this is a practical aspect. So that also you have to remember that, yes, the older, it's not that the older system was all bad. Before NHM, the health system was being managed. So you may ask that, sir, before 2005, what was there? But many achievements were done before 2005 also. But the system was, the government system was meant in a way that there are many checks and balances. Okay. So and that's why so what they felt, what the bureaucrats felt is that all those checks and balances are probably being misused, and then we are not able to provide services. So yes, they had provided, and I think lot of improvement in the past 15 years in health system is attributable to this National Rural Health Mission. You can see there is tremendous reduction in IMR. Now this MMR has come to around 116. So it was more than 200. So all these things are there. This IMR, infant mortality rate, is around 40, 43 or something. Okay, so those things are there. But also if you see, there is also the other aspect also is there. Yes. So that part also is there as a practical aspect. Then again, there is monitoring against standards. Okay, so that part, to explain it with some examples, is like there is something called IPHS standards. So there is IPHS, for example, this room is there. How big this room should be there? This is our ASHA meeting room. And you see there is a whiteboard here in PSC. There is a electricity connection is there. So how big this room will be there? It's not that it's part, because it's built according to IPHS. Okay, there is a particular plan is there. So whether you're following IPHS standards, delivery room is there, how big it should be there. Cold chain room is there, where vaccines are kept, how big it should be there. So all these standards are there. You can, if you just search IPHS, that is Indian Public Health Standards. So it will have everything for a sub-center. Okay, if a sub-center is equipped with a facility of delivery, then what facility should be there, how much area should be there. So everything is given in that. Same thing for a PHC, for a community health center, district hospital, they have IPHS for all these things. Okay, and there is something called facility surveys. Okay. So that part also is there. So health facility survey part also is there. So that has to be understood that there are checklists are there. Okay, that these particulars, for example, in a delivery room, all this, there is a particular checklist will be there, whether all these facilities are there, whether soap is there or not, whether gloves is available or not. Okay, so all these things are there in that. Okay, whether the register is updated or not. Okay, whether the delivery register is updated or not, whether birth certificate is being issued or not, within how many days it is being issued. So all this, for example, immunization is there. So all these checklists are there. For example, for monitoring, for a block level immunization monitoring checklist is there. For example, if there is a immunization service is being given in the outreach, so for that also there is a monitoring checklist. And there are checklists and formats, monitoring tools which are specific for a disease. For example, if I am going for fighting out the leprosy program, leprosy eradication program, for that also block level leprosy, that those facilities checklist is there, that related to leprosy program, what all things we have to see. So those facility survey are there. Then independent monitoring committees are there. Okay, but they have to be utilized, they have to be implemented to monitor. And there's something called common review missions. So usually what happens is, like every year, this year they have not been able to do, but every year they usually come to a state and they choose 2 districts. For example, in 2018, Jodhpur district was selected. Okay, so 2 districts are taken randomly, one poor performing district and one which is not so poor performing. And then they thoroughly they see all the aspects of the National Health Mission. Okay, and so that aspect is there. Then there is a consolidated report you can also download. You can see their reports are there in the website. And similarly there is something called joint monitoring missions. So whenever a program happens, for example, in our IDSP class we had seen that there was a joint monitoring mission, and after that only the online system was strengthened more. There is something in that. In 2015 there was a joint monitoring mission. So those missions also take place in which there are people from various backgrounds. Okay, and then independent monitoring is done with stakeholders and with international experts are also done for a particular program. For example, if a program is going to reach a elimination date of elimination target, for example, Kala-Azar is there, visceral leishman. For example, lymphatic filariasis is there. So all leprosy is there. So all of these are having 2020 as a date. Okay, as a date to achieve their targets. So then there will be a independent monitoring will be done. Government of India will collaborate with states, and then so those aspects also are there. Okay, so within National Health Mission, this is there. Okay, so for example, this is this national monitoring. So in this, for example, this is monitoring for mass drug administration. So what is this? Can you tell? Can anyone tell? What is this cylindrical box kept in this? Students are there? Yes, albendazole, very good. Anamika has answered. Yes, it is albendazole, and this carton is DEC, diethyl carbamazine. Okay, so it is used for mass drug administration, which is used for lymphatic filariasis elimination. You would have already studied what is the logic behind this in your albendazole, and this is DEC. You find out there is something called DEC. And okay, so this is the thing. So for example, a monitor's training is happening. Okay, this person is filaria inspector. They are from this filaria. Other people are from WHO, and he is a vector-borne disease officer. So like that, there is a team, there is a training is happening. So this is part of monitoring. So any program is happening, monitoring has to be done. So this is there. So this is training of monitors. Monitors can be hired externally. So these are there. For example, this is a monitoring. This is the MDA program. You can see this is albendazole here, and she is writing in the register. MDA. We have this MDA register. So that is there, and then she is carrying this DEC also, and the drugs are being given. Okay, so this is one program in a campaign. Then various aspects are there. We'll see what all programs are there. This is a district level review meeting which is happening with the civil surgeon or civil chief medical officer, which is happening at the district level. So these review meetings has to happen actually at a weekly basis. So these aspects are there. Okay, so we'll just briefly see what is the structure of NHM. Okay, already you are aware of that. So already you know. So we'll start from the base, which is the sub-centers. Sub-centers already you are told is a 5,000 population. Village Health and Sanitation and Nutrition Committee, that is at a village level, that is around 1,000 population. Then already we have seen primary health center around 30,000 population, and community health center at around more than 1 lakh population, 1,20,000. And then we have a district health society at district level, which can take decisions for the district. State health society, which can take decisions for the state level. Okay, And then it's all being guided from a central level. Although you should know that health is a state subject, but lot of technical guidance is being provided by this Ministry of Health and Family Welfare. Okay, so practically, actually, although it's a state subject, practically we have a lot of this guidance which is coming from the central level. So we have other supporting agencies also. For example, we had discussed what is this NHSRs, National Health Systems Resource Center, and there is this National Institute of Health and Family Welfare. So these are all the nodal agencies which are helping in training, conducting training. You can also apply for it. Suppose you are interested in some training, you can see their website and you can apply. So they have, if you are eligible, they will give. So that type of, nowadays there are a lot of webinars and online, if it interests you. So that is there. And there is something called National Program Management Unit. So those are there to provide the technical support. And then similarly, just the mirror image of that at the state level. So there is this State Institute of Health and Family Welfare. Those have been established. State Health Systems Resource Center, State Program Management Unit. So similarly, this will be at state level to support the activities at the state level. Okay, because India is a large country, and suppose something which is valid for Rajasthan may not be valid for Telangana. Okay, so there are different priorities in different areas. Okay, so that is there. And then at the community level, you have to remember involvement of Panchayati Raj institution. This is very, very important. That is a very important key thing in NRH. That's why community engagement, we tell it as a first point. Okay. And then what is this organizational structure at the district level? Okay. This you might be curious to know. So we have a district health society. So usually district health society has a chief district magistrate, DM as a chairman. And then we have the chief medical officer as the member secretary. Okay. And then we have, so chief medical officer is known as civil surgeon in some states. They are known as CMHO. For example, in Rajasthan, they are known as CMHO, Chief Medical and Health Officer. Some states, they have made a district health. So there are different nomenclatures out there. For example, in UP, they are known as CMO, Chief Medical Officer. In Bihar, they are known as civil surgeon. So basically, it's the same person. Okay, so nomenclature may be different. Okay, CMHO. And then Assistant Chief Medical Officer is there, and then usually there will be a nodal person who will be allotted for National Urban Health Mission. Okay, and under that there are different district program officers who is there. For example, for TB program, all this district level communicable disease control programs officers will be there. Then this RCH officer is there, who is very important for immunization, and this RMNCHA program. So one person is dedicated is there for district RCH officer. Okay. So these people are usually medical, from medical background, and then we have other people who are usually from the management and accounting background, is like district program manager, as I had already told, who is managing the programs. District account manager will be there. Then there is district communication mobilizer, who is looking after the ASHA aspect. So communication aspect and mobilizing the community is the ASHA's work. So there will be a block level, block communication mobilizer post also will be there. And there will be a district communication mobilizer. So these all posts are created under the NHM. And there will be one district monitoring and evaluation officer. So they are responsible for the monitoring aspect. So continuous monitoring. So those systems are put in place. Okay, that these things are, their dedicated staff are put in place. Okay. So just we'll see what are the programs. Just briefly we'll see so that we'll get an idea. That one is this RMNCH plus A. This is a very important. So NRHM is a very big umbrella program. Under this we have RMNCHA. What is this RMNCH plus A? This is reproductive, maternal, neonatal, and child health. Okay, and plus adolescent they have had. And then we have communicable disease program, non-communicable disease programs under that. So RMNCHA, there are separate classes for RMNCHA also. So I will not go much in detail. So it includes services for pregnancy and childbirth, newborn, child, adolescent health, and throughout the reproductive year. So RMNCHA will provide services, for example, delivery services, the immunization is there. All those aspects, everything will be are there. And this RMNCHA also is a very big part of NHM itself is a big part. And under that, the more than, you can see around more than 1/3 or half of it is taken by RMSCHA. That budget is there because reproductive and child health is very, very important. Because you can see the main target is this infant mortality rate and maternal mortality rate has to be. So that's the main target. So this is a very important part that you have to see. When you go to the field, although there is one class for each of it, but when you go to the field, you will see that RMSCHA will be forming the bulk of it. Okay, so this, just remember the three key things. RMSCHA, communicable disease programs, all these programs are integrated under this umbrella of NHM. That you have to remember. National Health Mission is a thing. So whenever somebody is asking, you should be able to tell that within NHM, all these things are there. Okay. These goals are there. Already we will see it in RMSCHA plus class. So now we will not go much in detail. Okay, we repeatedly will see that. For example, just remember one MMR goal is 100, was 100 per 1000 live birth. That was there for 2017. So now we have reached 116. So although we are a bit late, but we are approaching them. Just remember one goal. Okay. And IMR goal you can remember is 25 per 1000. Then there are various communicable disease programs are there. So that separate classes are also there for that. For example, we had our IDSP class, Integrated Disease and Surveillance Program is there. Vector-borne disease control program is there, in which all the vector-borne diseases like malaria, filaria, dengue, chikungunya, Japanese encephalitis. So 6 vector-borne diseases are there. Then TB elimination program that is there. Then we have leprosy eradication program. Okay, that is there. AIDS control program is there. Rabies control program is a new program. Rabies and viral hepatitis control program. These are comparatively newer programs which are also under this communicable disease programs. And it is there in your part textbook and separate classes will be taken. Okay. And we have different non-communicable disease programs. So for example, one is this for this NPCDCS, diabetes, CVD and stroke. Then we have one for control of blindness. You will have this class next week by Dr. Shrikant sir. Then for deafness it is there, mental health program, oral health program, then relatively new program that is healthcare of elderly and iodine disease deficiency disease control program. This is a very old program. For example, iodization of salt is there and tobacco control program. So these are some of the programs. These are all under NHM. So that you should remember. So that is all. Any doubts? Do you have any doubts? Shall we recap? So this is the slide. Do you have any doubts? All are silent. Again, number of people have reduced. It was 84 and now it is 73. So just a recap. So when the 5 key things which you have to remember about NHM is these 5 things. Community engagement, health system strengthening, human resource management, financing, public health financing and monitoring. It's very easy. Like you remember manpower, materials, methods. So based on that we have there. Okay. And then we have to monitor it and we have to engage the community. So these 5 things are the key components. Based on that you can remember. And then programs, you remember the structure of NHM. This is structure is given in your books. And then you can remember the key programs which are there under that, which are RMSCH plus A, communicable disease and non-communicable disease. So do you have any doubts? You can ask. So I will give my email ID also. If you have any doubts, you can send me an email. My name is Dr. Suman Saurabh, in Community Medicine Department. So if you have any doubts, I'll upload a slide also. Okay. Okay, thank you. So if you have any doubts later also, many times you go back and you have some doubts, then you can email me. I'll upload the